Hey, welcome back. Let's go through the anatomy and the nerves of the spinal cord. So, it's important to know that the spinal cord is longer in children and it's shorter in adults. So, it ends at L1 in adults and L3 in children. And it's surrounded by the meninges. The epidural space, especially in children, is going to be made out of a fatty tissue, and it tethers the spinal cord in the spinal canal, and it becomes less and less with age. And the subdural space is going to be within the dura and the arachnoid matters, and that is going to not really contain the CSF. The CSF stays in the subarachnoid. The subdural is kind of like where injuries kind of form, unfortunately. The pia mater is vascular, and it has something called the denticulate ligaments holding it in place. There it is. It's kind of like these little points. And they have the filum terminale, which is just another ligament that holds the spinal cord in place towards like the end of the spinal cord. So the filum terminale will extend from the conus medullaris to S1. So this is the filum terminale, and it's a part of the pia mater. And it's made out of the internal filum, and that lies within the dural sac, and the filum externum, which lies outside the subarachnoid space. So there's 2 points of contact. We're not really sure what they do. It could be for stability. It could be for some nerve conduction because they are made out of a couple of nerve fibers, but not a significant amount. The subarachnoid septum will attach the pia mater to the arachnoid mater, and there it is. And the linea splendens is going to be the septum in the anterior medial fissure. So this is the main septum. The ligamentum denticulate will extend laterally to anchor the spinal cord in the middle of the subarachnoid space, and they contain the ventral and the dorsal root ganglion. The ligamentum denticulata is important, especially in surgery, because it's a guide to see the T12 or L1 nerve. It's pretty distinctive because while the rest can be kind of just like little points, little waves, it looks like a fork. The ligamentum is like a fork. So below the ligamentum would be the L1, above would be T12, and then from there you kind of count up to whatever thoracic or lumbar vertebra needs surgery. So in other surgeries, especially when you deal with pain, you can resect the sensory tract, and the scalpel is going to be put in front of the ligament. So here, so it'll be put in front, and that would be if you need to resect it, you would be cutting through the lateral spinothalamic tract, and that's the only tract that carries pain and temperature. And if you need to resect the motor tract, so in cases of like spastic paralysis, contracture, or like tremors, you would put the scalpel behind the ligament and then resect it there. The anterior median fissure is going to have like the anterior septum in it, and then the posterior medial sulcus will have a septum as well. There is the subarachnoid septum that separates it deeper. The posterolateral sulcus is kind of like one of the widest ones, and those contain the sensory tracts, and then the anterolateral is going to contain the motor tracts. It's a little bit harder to see, but you can sort of see it right here, and presumably it'd be present on the other side as well, because it's mirror images. But the important ones to know is the posterior medial sulcus, anterior medial sulcus, and the posterolateral. And from there, you kind of like orient yourself to find the dorsal root ganglion, the anterior gray column, posterior gray column, etc., etc. Okay, so you should remember this from anatomy, but in the cervical region, the nerve roots go above the vertebra, so +1. That's why there's an extra cranial nerve. So cranial nerve will exit below cranial nerve something because it goes up. Below the cervical region, in the thoracic region, the nerve will exit below the vertebra, so it's like a -1. And then the lumbar region, same thing. So only the cervical region is different. The conus medullaris will start at, the L1, and it extends to the sacral area. The Cauda equina is going to be made out of the conus medullaris and the filum terminale, and it contains the 4 pairs of the lumbar nerves, 5 sacral, and the 1 coccygeal nerve. And it forms the lower motor neuron to the lower limbs and the anal sphincter. And it contains the parasympathetic innervation for the bladder. So, there's something called a Cauda equina syndrome, and it occurs when you fall really hard on your backside. It can be due to like a fall from a great height, or falling from a horse, or like landing too hard in a horse. That's why it's called a saddle injury, and it also presents in a saddle region. So if you have a Cauda equina syndrome, there is going to be de-innervation in like the medial aspect of the thighs and the buttocks and the anal like sphincter, and in the males there's going to be de-innervation in the genital region. Okay, so we'll go through the brainstem a whole lot more in a couple lectures, but in general, they're made out of the medulla oblongata, pons, and the midbrain. Gives rise to cranial nerves 3 to 12. Pyramids are where they cross, and there is going to be the stria medullaris that divides the 4th ventricles into the upper and the lower parts, and they have a lot of like nuclei. So the area prostrema is this like tiny little area, I want to say like right, well, let's see, here. And it's important because it contains no blood-brain barrier, and it's the vomiting center of the brain. Vomiting centers can be triggered by like higher cortical centers, so taste, sight, smell. And then it can be triggered by, your GI and motion sickness, and all kind of releases serotonin, and it's going to go to the muscarinic dopamine. Oh, it's going to go to the, I don't know what this is, the cortical tract. Definitely go through that later. Like, that's not that important right now. But all of these will send signals to the area prostrema, and that's when people start vomiting. So there's going to be cranial nerves 6, 7, 8 around this area. The locus ceruleus, important, is going to make melanin and norepinephrine. And it's in this area, there's going to be the optic chiasm. So of course more like, anterior, but it's kind of important to know the plane. Okay, so the rhomboid fossa is this area, and it's the 4th ventricle filled with the 4th ventricle is filled with cerebrospinal fluid, and it communicates with the central canal and the aqueduct of Sylvius. There are these recesses, and they're the extensions that makes the rhomboid shape, And the upper triangular part, it would be the posterior pons, and the lower triangular part would be the posterior medulla. So all these recesses will contain certain nerves, like the lateral recess will contain the vestibular area, but more importantly, it's divided once again by the stria medullaris, and the stria medullaris is just it's just like a anatomical landmark. So you know where the rhomboid fossa is and where the division is. So this would be the upper triangular part, and this would be the lower triangle part. And then right in here would be the area postrema. Okay, so the fourth ventricle is bound by the inferior cerebral peduncle, and the gracial and the cuneate tubercle. And above, it's going to be covered by the superior cerebellar peduncle, and the roof would be the cerebellum itself. The floor would be the rhomboid fossa, divided by the median sulcus, and it contains like cranial nerve number 7. And the lateral to the sulcus limitans is going to be the vestibular area. Superior would be the superior fovea. Inferior would be the inferior fovea. And once again, there is going to be the locus ceruleus in it. The hypoglossal triangle is the medial part, and it lies over the cranial nerve 12 nucleus, and the lateral part will lie over another structure called the nucleus intercalatus. More importantly, the vagal triangle will overlie the cranial nerves of 9, 10, and 11. So the area postrema lies between. It's made out of very vascular neuroglial tissue. And here's the rhomboid fossa again. Here's the sulcus limitans, lateral, medial, area postrema. Okay, so fourth ventricle tumors are really rare, but the most common out of all of them are the medulloblastoma, and it presents in children. And the signs would be cardiac, respiratory irregularities, tachycardia, vasomotor disturbances, of course, because it's all affecting the medulla. And the result of all of this would be internal hydrocephalus. There's going to be a block, so the CSF won't be able to drain. Okay, so internal features of the spinal cord. The nerve cells are going to be multipolar, and there are 2 different types. The Golgi type 1, which is the large neurons, and those are generally in the brain. This is Golgi type 1. And Golgi type 2 would be the small local circuit neurons. These would be like intercommunicating neurons. They lie either within the segments or between the segments, and they do not leave the gray matter. So they would either lie like within here or within here. The motor neurons are going to be the anterior and lateral horns, and they have the alpha and gamma motor neurons. It controls the alpha motor neuron will control the extrafusal muscle contraction, while intrafusal contraction would be controlled by the gamma motor. So it's going to be the neuromuscular spindle. This contraction is not like the contraction of the actual muscle fibers, but the neuromuscular spindle. There's a distinction. The first, the intraspindle will contract, and that would be the signal transmission, and then the entire muscle or the extrafusal muscles or fibers will contract. Sensory neurons are a little bit more straightforward. They just have a free nerve ending, and they just send the information up the ascending tract and into the posterior horn or the dorsal root ganglion. So the nerves are going to be clustered in all these groups. In the anterior gray column, there's going to be the medial, the lateral, and the central nuclei. In the posterior gray column, there's going to be the substantia gelatinosa. Oh, pointing to the wrong thing, sorry. The posterior marginal nucleus, the nucleus proprius, and those are going to be the visceral afferents. And there's also the nucleus dorsalis, which is known as Clark's column. In between would be the intermediolateral and the lateral, and this would be the intermedial cell groups. And not every group is present in every single region, so that's kind of important to know. The reticular fibers would only be in the cervical and the sacral region. Okay, so to go further into the anterior gray column, the medial would be most of the length of the spinal cord. They innervate the axial muscle of the neck and the trunk. And the lateral would only be in the cervical and lumbosacral enlargement. They supply just the limb muscles. The central or intermediate groups would be controlling the diaphragm. The lumbosacral group is kind of unknown, but it's found only in L2 to L3. And the spinal nucleus of the accessory nerve, so cranial nerve number 11, would be in the part of C1 and C5. The accessory nerve has two nuclei, one in the brain and one in the spine. Okay, in the posterior gray column, the substantia gelatinosa is mostly only at the apex of the gray column, and it is going to extend throughout the length of the spinal cord. It's made of Golgi type 2 fibers, and they convey pain and temperature, and it's continuous with the spinal tract of cranial nerve number 5. The nucleus proprius would be most of the cells, and it extends throughout the whole length of the spinal cord as well. It is going to be responsible for proprioception, movement, 2-point discrimination, and vibration. 2-point discrimination is you can tell that the two things are touching you at the same time. The nucleus dorsalis would be the medial part of the posterior column, and it's going to be in C8 through L2 or 3, depending on the person. And it also provides proprioception, but mostly from the muscles and the joints. And it provides temperature and pressure from the, or touch, sorry, that should be touch and pressure from the trunk and the lower limb. The visceral afferent nuclei would be lateral to the nucleus dorsalis, and it would be only in T1 to L2 or S2 to S4, so this would correlate with the intestines, right? The intermediate nuclei would be the intermediolateral nucleus. It's only around T1 to L2, and they are the preganglionic fibers of the sympathetic nervous system, and they leave with the anterior nerve root. The intermedial group, I'm sorry, I always point at the wrong thing. This is the intermediolateral, this is the intermedial-medial group. This lies only within S2 to S4, and it's the preganglionic fiber of the peripheral nervous system, and also leaves with the anterior nerve root. Rexid lamina would be just like an organizational structure. So the first one would be the posterior marginal nucleus. Second one would be the substantia gelatinosa. 3 and 4 would be the nucleus proprius. 5 and 6 would be the base of the dorsal column. 7 is the nucleus dorsalis, anteromedial, lateral, and intermedial nuclei of the lateral horn. 9 and 10, or 8 and 9, just skip that, would be the medial and lateral groups of the anterior column, and then 10 would be the gray commissure and the substantia gelatinosa. So this is just like an anatomical organization. So if the text would refer to like Rex lamina number 5, you would know that would be like base of the dorsal column. White matter is going to be made out of the anterior, the lateral, and the posterior funiculi. And they all contain the ascending and descending tracts. Descending would be motor, of course, and then ascending would be sensory. Okay, so the anterior tracts, there would be the anterior spinothalamic, which is responsible for touch and pressure. The spinotectal and spinal olivary would be responsible for proprioception. Lateral funiculi would be posterior and anterior spinocerebellar, and it's responsible for unconscious kinesthetic sensation. What does that mean? So you would know that like when your eyes are closed, you are still touching something. You might not be paying attention to it like when you go to sleep, but you know sheets are touching you. You know that your pillow is touching your head. The lateral spinothalamic tract, pain and temperature, only one that conveys it. That's the important one to take away from all this. And the spinal reticular would be responsible for consciousness and awareness. The posterior funiculi, gracilis and cuneatus, is responsible for tactile sensation, tactile localization, and tactile discrimination. So how we touch, where it's touching us, and whether we can discriminate whether it's sharp or smooth or blunt. Also responsible for conscious kinesthetic sensation. So when you look at something, like I am looking at this pencil in my hand, you can feel it. It's also responsible for vibration and stereognosis. Stereognosis is when you close your eyes, you're still aware of where your body is in space, and like if you turn your head, you know that you're still sitting up straight. You know your head's turning to, let's say, the right. But you can orient your body. There's certain tests, especially after like car accidents, after like head trauma, that you test for this. I don't remember the exact name, but I know you ask the patient to close their eyes and stand up straight. Somebody who has a damage to the posterior funiculi tract would like fall over immediately. Okay, so the descending tract, anterior and lateral cortical spinal tracts, is responsible for voluntary and spine movement. Lateral vestibulospinal tract is going to be responsible for your muscle tone. Anterior vestibular spinal would be responsible for the position of the muscles. Reticulospinal would be responsible for voluntary and reflex movements. Tectospinal would be reflex of the head to stimuli. Okay, so this one's a little bit more nuanced than that. It's like if you hear something, especially in your name, you turn your head immediately. And when you turn your head immediately, there's a lot of things that your brain has to do. So they coordinate the eyes, and they have to coordinate your the intracochlear like nerves, because when you turn your head there is movement, and they have to accommodate for the movement, especially in the endolymph, and tells your body like, hey, okay, so there has been a change in posture, there has been a change in position, your head has turned, and all of this has to play together perfectly. Otherwise else you get like vertigo. Vertigo is when like all the reflexes are not coordinated. And the rhombospinal would be maintaining the tone of the skeletal muscle in particular. Okay, so the pyramidal tract would be the direct motor tract. So just, send a signal, muscle moves. And it's divided into the lateral and the anterior cortical spinal tracts. The extrapyramidal tracts would be indirect movement, It's going to connect indirectly to the muscle. There's going to be a synapse to something else. The cerebrospinal tract comes from the red nuclei of the brain. It lies in front of the lateral white column. It maintains skeletal tone. I think I already said that. Tectospinal, coordination. Vestibulospinal is going to maintain posture. Reticulospinal would be coming from the reticular formation, and from the medial area to the pons is going to be uncrossed, while from the lateral tracts coming from the medulla will be crossed, and it's going to maintain muscle tone, and the olivospinal will come from the olive, of course. Okay, so the pyramidal tract comes from the corona radiata, and then from there it goes into the internal capsule, and then it goes through the crus cerebri, and then they cross or decussate, in the medulla, and a good majority of the fibers will cross at the medulla, and that will make the lateral cortical spinal tract, and then the remaining fibers will make the anterior cortical spinal tract, and then from there it also crosses, but it decussates in the level of the spinal cord. So if the lesion is in the medulla, there's going to be a paralysis of the contralateral side, because it decussates below the medulla. If the lesion is at the spinal decussation, the paralysis is going to be ipsilateral, because it will have to it has to be above the spinal decussation, or below the spinal decussation, I'm sorry, and then that would be ipsilateral. Okay, so the posterior column tract would be made out of the gracilis medial, the fasciculus lateral, and the ventral and lateral spinothalamic tract, along with dorsal spinocerebellar tract. So here's the lateral. Remember, it decussates in the spinal cord. Let's see. The fasciculus gracilis is going to be medial. Cuneatus is on the lateral. Okay, so the fasciculus gracilis is also known as the tract of Gall, and it goes below T6, and it innervates the lower limbs. Fasciculus cuneatus is going to be the tract of Burdak, and it's above T6, and it provides innervation to the upper limb. And these are the functions it plays. So touch, pressure, stereognosis as well. So you know where your limb is in space. If you raise your hand, you know your hand is, let's say, at the level of your shoulders. Conscious proprioceptive sensation, vibration, and it goes up to form the medial lemniscus in the medulla, to the pons, and the midbrain. Okay, so anterior spinal thalamic tract would be non-discriminative touch and pressure. It contacts the nucleus proprius at lamina 4 to 7, and it crosses in the anterior white column. It's parallel to the medial lemniscus in the brain, and the lateral spinal thalamic tract, pain and temperature, remember, and it will cross and ascend in the lateral white column and ascend as the spinal lemniscus. So medial lemniscus is the anterior, lateral is going to be the spinal lemniscus. Since it's so close to the canal, it can be compressed if there is any enlargement of the spinal cord canal. So the posterior cerebellar tract, they do not cross. They go straight up, ascend the lateral white column, and enter the cerebellum. And they're responsible for unconscious proprioception, sensation of the lower body, touch and pressure, and it makes up the C8 to L3 dorsal root ganglia. The accessory cuneate nucleus is going to be the unconscious proprioception of the upper limb. The anterior spinocerebellar tract is from L2 to L3, and it relays the neurons in lamina 5 to 7. They're crossed and then uncrossed to go to the cerebellum, and responsible for, once again, more proprioception, crude touch, and pressure. So there's no discrimination. You just know something is touching you. Responsible for the posture and movement of the entire lower limb, and it synapses in the substantia gelatinosa, and it goes to the anterior spinothalamic tract all the way up into the superior cerebellar peduncle. Okay, so the innermost spinal cord is going to be supplied by the radicular arteries. The main ones you need to know are the anterior radicularis magna. So that's going to come from the intercostal arteries. And these are the major blood supplies to the lumbar and the sacral cord. The vulnerable zones to ischemic necrosis is T1 to T4, along with L1. It's just narrow there, and is drained by the longitudinal veins, the internal venous plexus, the azygous vein eventually, and the basilar venous plexus. So all of this will dump into the azygous vein. Thank you for sticking with me. Thank you for your attention, and good luck studying.